Well, I want to welcome everybody. Dr. Addrizzo-Harris and I are coming to you from Brisbane. So it's about 7 a.m. our time on Thursday. And today's the last day of the conference, but we wanted to give you some of the highlights. And we're likely going to have a part two to this that we'll schedule. Um, you know, maybe in August, maybe in September, but we will keep you updated. Um, so my name is Mary Kitlowski. I am the president and founder of Running on Air, and we do webinars like this on bronchiectasis. One of our other big focuses is on supplemental oxygen. And you can follow us on social media, and you can sign up for our newsletter. We have a monthly newsletter we send out. And actually, by signing up for this webinar, you will receive our August newsletter. One of the big things we do is produce a portable oxygen concentrator comparison chart. This is for people on supplemental oxygen to just help them see what portable options there are and choose the device that best fits their needs. So I will be moderating today with Amy Lietman, who is the president of NTM Info and Research. And I will introduce Amy now to talk about NTMIR.
Thank you, Mary. Hello, everybody. It's a pleasure to be here from wherever in the world you are. Thank you for joining us today for this World Bronchiectasis webinar. I'm Amy Lietman. I'm president of NTM Info and Research. We are a patient advocacy group for NTM and for bronchiectasis patients. A lot of you probably know us already. A lot of you may also be part of our patient support network. If you are looking for a patient support group, please log on to ntminfo.org for more information. For those of you who don't know, we also celebrate World NTM Day, and that is coming up on August 4th. So July is all about bronchiectasis. August is all about NTM. And the two of them sort of are like apple pie and ice cream. So that's why we put them next to each other. So we hope you'll also join us in August. We're going to have several webinars going on. Again, thank you for joining us today. For those of you who don't know, if we are experiencing some technical difficulties, I just want to point out that Mercury goes into retrograde on July 17th. And in fact, in Brisbane, it is already July 17th. So we may have some technical difficulties and we will fix them as we go along. Anyways, I'm going to pass it back over to Mary and we will get this webinar started so you can learn all about what's been going on in Brisbane at the World Bronchiectasis Conference.
Thank you, Amy. I just want to mention that this event is being sponsored by InSmed. We appreciate their support. And a few housekeeping items. You can put your questions in the Q&A, and after she's finished, we will get to as many questions as we can. This webinar is only going to be an hour. Like I said, we're in Brisbane, and the conference is starting 8:30 a.m. our time. So, and then just a reminder that Dr. Addrizzo-Harris cannot give any personal medical advice in this webinar. So I would like to introduce Dr. Addrizzo-Harris. She is the Fiona Stanley Druckenmiller Professor of Pulmonary Critical Care and Sleep Medicine in the Department of Medicine at the NYU Grossman School of Medicine. She has an extensive background in bronchiectasis and non-tuberculosis mycobacterial infection and medical education. She serves as the Associate Director for Clinical and Academic Affairs and is the Director of the Bronchiectasis and NTM Clinical and Translational Program at NYU. She is now serving her 24th year as the Program Director of NYU LH's Pulmonary and Critical Care Medicine Fellowship. She is currently the chair of the Clinical Care Network Steering Committee of the Bronchiectasis and NTM Association. She is also the chair of the annual North American Bronchiectasis and NTM Symposium at NYU each December. She served as the chair of the 6th World Bronchiectasis and NTM Conference in 2023 and is a past president of the American College of Chest Physicians, CHEST, and the Association of Pulmonary Critical Care Medicine Program Directors. She is a passionate educator on the topic of bronchiectasis and NTM and is focused on bringing high-quality care to patients living with these diseases. She has lectured extensively on bronchiectasis and NTM lung disease and is primary investigator of many clinical trials in bronchiectasis and NTM lung disease. So welcome, Dr. Addrizzo-Harris.
Okay, thank you so much, Mary. And thank you, Amy, for inviting me to speak today. Good, I guess, good evening to those of you who are joining us from the eastern part of the US. Good afternoon to those of you on the western part. We are here on Thursday, the last day of what has turned out to be a phenomenal World Bronchiectasis, the 8th World Bronchiectasis, done together with the Lung Foundation of Australia and the University of Queensland here in Brisbane, led by 3 phenomenal faculty experts, all women, very proud to say that, Dr. Lucy Burr, Dr. Lucy Morgan, and Dr. Rachel Thompson. It's really been an unbelievable series of lectures. I'm just going to highlight a few. What we will try and do, as Mary said, is perhaps there is a patient session that's been happening, and potentially we can get those slides from the Lung Foundation of Australia, and then do something in the early fall to go over those with you, so to capture things that I may not hit today. So the conference started off with a phenomenal presentation on Monday afternoon here. It is the largest World Bronchiectasis Conference that we've seen to date. It has over 1,000 attendees and has 97 speakers, which include 11 rising stars, phenomenal researchers in the space of bronchiectasis and NTM, particularly fellows and junior faculty that have also been invited to take part. There were over 164 abstracts submitted, and there is representation from 6 continents and 44 countries are represented. So really quite phenomenal. Of course, as you would imagine, they had a phenomenal opening speaker, and that was Dr. James Chalmers from the University of Dundee. Dr. Chalmers talked about celebrating the last 20 years of bronchiectasis research and clinical care and where we have come over the years. So let me just highlight a few of the studies that Dr. Chalmers discussed that are going to be key for many of you living with bronchiectasis. Of course, Dr. Chalmers has done most of his research in bronchiectasis, looking at inflammation, particularly defining the neutrophils part in inflammation within patients with bronchiectasis. And many of you have heard about the dipeptidyl peptidase 1 inhibitors that focus on reducing neutrophil serine proteases and the inflammation that is produced by that. He reviewed 3 studies that are now completed and going quite important for potentially an FDA-approved medication that we may hear about in August. So the first study, just to is the Aspen Aspen phase 3 trial. As many of you know, that trial will be coming up for potential. That drug, brensocatib, will potentially be FDA approved this August. That was a phase 3 randomized double-blind placebo-controlled 52-week study. Looking at 2 different doses of brensocatib, 10 milligrams and 25 milligrams compared to placebo. and there was very positive endpoints. The pulmonary exacerbation rates were reduced by about 20% for both dosings of 10 and 25 milligrams compared to placebo. The time to the first pulmonary exacerbation was prolonged, so patients were staying healthier longer, and that was also about 20% for both 10 milligrams and 25 milligrams. And with the 25 milligram dose, there was also a reduction in the rate of decline of the patient's pulmonary function. We all know that with repeated exacerbations, especially severe exacerbations, patients lose pulmonary function. And the higher dose at 25 milligrams helped reduce that rate of decline of pulmonary function. And then the wonderful thing about the drug is that it was extremely well tolerated with no significant adverse events. So that was one trial. The second trial is a phase 2 trial from Boehringer Ingelheim Airleaf phase 2 study. The drug has a number at BI 1291583, and that was another randomized double-blind placebo-controlled trial of 24 to 48 weeks using several doses of the drug, 1 milligram, 2.5, 5 milligrams compared to placebo in 322 patients. And this was, as I said, a phase 2 trial that showed that there was a reduced risk at both the 5 and 2.5 milligram dose of pulmonary exacerbations by an average of 30% over the treatment period. And also it reduced the annual rate of exacerbations. The 2.5 milligram dose was successful at doing that by 32%. So extremely important drug that is going to now be moving into a phase 3 trial this year. And the third trial that was briefly discussed was a trial that was done in mainland China, another DPP-1 inhibitor called SAVE-BE phase 2, a study of a drug HSK 31858. This drug, again, was given at 20 milligrams or 40 milligrams for 24 weeks. And again, there was a significant reduction in annualized frequency of exacerbations. And hopefully we will be seeing more of this drug in a phase 3 trial soon. So the key here is that inflammation, neutrophilic inflammation is an extremely key part of what is going on in patients with bronchiectasis, and reducing that inflammation is quite important. And one of the things that Dr. Chalmers showed with a lot of evidence is that we should be thinking about this active inflammation as being immunosuppressive. The neutrophilic inflammation, we used to think that, oh, it's great. It's calling a lot of cells to come and fight, and we're going to be more capable of getting rid of the disease. However, he has shown that many markers that are related to our immune system are reduced when this inflammation goes haywire. So by reducing the amount of neutrophilic inflammation, we're making patients more able to fight the diseases themselves. So more to come on that, and I'm hopeful that we will be able to have an FDA-approved drug by the end of the summer. I was lucky enough to be asked to give one of the opening session talks, and just to quickly highlight my talk, I spoke about the new care paradigm that we are delivering in the United States. As many of you may know, the COPD Foundation has worked together with the bronchiectasis community in the United States. They have been supporting the registries that many of the big sites, many of the sites that you may go to where we're entering patients, and the United States registry has more than 9,000 patients. It's been working together with the COPD Foundation. Our sites have been working together since 2007, almost 20 years. What has happened is that we have started a new association underneath the umbrella of the COPD Foundation called the Bronchiectasis and NTM Association. That association has 3 leading faculty working together with it on top of a very large steering committee with many physicians from across the United States. I am chairing the clinical arm. Dr. Chuck Daly is chairing the research arm, and Dr. Tim Axmit is chairing the education and global awareness arm. And we have started a clinical care network system. We have currently 33 centers across the United States, with the hope that we will get to 100 or more centers over the next year and a half. The goal that every state should have a center, and that in areas where there's dense populations will have several centers, not only at the universities, but hopefully at the public hospitals. This group of physicians with many of the centers have very robust clinical teams that include respiratory therapists, nurse practitioners, nutritionists, social workers, et cetera, will be working together to care for patients and also to provide education to those who are not at centers. Part of the goal here is that we will be expanding not only the clinical care, but access to clinical trials. And we will be developing a clinical trials network so that we can recruit patients for clinical trials more efficiently and hopefully get some of these answers from clinical trials that take many years, reduce the time for us to complete the clinical trials. So there's a lot that we're going to be working on together with the Bronchiectasis and NTM Association. And I'm very, very excited in trying to deliver this care so that we can improve access, reduce the time to diagnosis for patients with bronchiectasis and NTM, and also to help with some of the misdiagnosis that's going on out there. There was a lot of discussion about precision medicine in the diagnosis and in the treatment of patients with bronchiectasis and NTM. As many of you know, there are many, many, many reasons why someone may have bronchiectasis. And there was a lot of emphasis, particularly by people such as Amelia Schumark, who is a physician in the UK, working with Dr. Chalmers, talking about how important it is to identify the underlying etiology for patients who have bronchiectasis and try and figure out a number of things. First, there were a number of lectures looking at genetics and the question, how much should we be doing to see if there is a genetic cause for a patient's bronchiectasis? Dr. Phil Holgreen from the University of Iowa, and I'm just looking through give me 1 second, I just want to make sure. He did a talk on the clinical significance of CFTR mutations. He's got a lot of experience within the CF community. And then but the question is, how much of this should be done for the patients who have non-CF bronchiectasis? Are we missing cases of primary ciliary dyskinesia? Are we missing cases of carriers of the CF genes who may benefit from some of the treatments that CF patients receive? So there was a lot of discussion about moving that more into the clinical realm. And I do think that within the next year, we will have more in the way of publications talking about how much of this should be performed in patients who present with non-cystic fibrosis bronchiectasis. I want to point out that the Bronchiectasis and NTM Association is actually working on a few consensus statements that are going to be coming out within the next year. 2 of those are going to be on should the state of the care for patients with bronchiectasis and NTM be beyond the guidelines. As many of you know, we have guidelines in bronchiectasis and NTM. 2 new guidelines will be coming out this year in bronchiectasis, one from the American College of Chest Physicians and one from the European Respiratory Society, but guidelines are only based on the evidence that's out there. And there are many questions that we have when we approach patients with bronchiectasis and NTM that don't have a lot of evidence behind them. How much testing we should do, which drug regimens should we be using? Should we be using macrolide therapy for suppression of exacerbations like azithromycin together with an inhaled antibiotic? There aren't studies that answer many of these questions. So Dr. Chuck Daly is leading a consensus statement on the treatment for patients with NTM, and Dr. Tim Axelman is leading one on patients with bronchiectasis. We also have a consensus statement that will be coming out on CFTR and genetic testing, who should be tested, what tests should be done, what should you do when you get an abnormal result back. So that will be guiding not only me, but many of the physicians out there when we treat patients and when we get all of the information back for some of these patients. Often we're not sure what to do. Let me point out that there was a lot of discussion about obstacles to care. As I said, there were 44 countries represented. And as you may imagine, many of the countries do not have the resources that we have in the United States or in Western Europe or even here in Australia. So looking at a lot of the countries, the low and middle income countries, and trying to figure out how we can better help those countries deliver care to their patients. Many of our physicians who were representing countries in Asia gave us a picture very different from what we see every day in our clinics. Many of them seeing 3 to 4 times the number of patients that we see in a clinic day and only having 5 or 10 minutes to see each patient without help from an experienced team. So how do we get more information out to their patients and get more resources for countries like that? That was a large part of the discussion. There was a rising star, which I will highlight, who was from our institution at NYU Bellevue, Dr. Robert Flowers, who was a research fellow with us and now will be staying on as an attending. He was invited to give his lecture on urban inequities in bronchiectasis, how race, ethnicity, and socioeconomic status shape outcomes. He is working together with Dr. Ashwin Basavaraj, as well as Dr. Shoshana Zah from the University of California, San Francisco, on putting together a statement on health disparities and inequities in the United States system and how we can better overcome those. And Pruhi showed with his data how there are issues with number of the underserved communities in accessing care. And so that will be something we will also be looking at over the next year with a lot of the physicians who work in centers where they've got obstacles to getting the right medications or even access to the appropriate providers. We heard a lot about NTM and MAC lung disease. As you can imagine, some of the key speakers there were some of our favorite faculty from National Jewish Health. Dr. Shannon Kasperbauer spoke a lot about managing side effects of the treatments that many of you are on. Talked quite a bit about the necessary monitoring to prevent some of the adverse effects, such as hearing loss, and such as GI discomfort, some of the ocular effects with ethambutol. And so she gave a very comprehensive lecture on how to best manage patients and educate patients, and that monitoring should be frequent for audiograms, blood testing, and eye exams while you are on azithromycin, ethambutol, and rifamycin for the standard treatment of MAC lung disease. Dr. Daly talked about patients who have refractory MAC lung disease or macrolide resistant lung disease, showed us that Those patients who have macrolide resistant lung disease have a very, very poor outcome, unfortunately, and it's extremely important in that group of patients that intravenous amikacin and surgery are part of the regimen. He also talked extensively about options for patients who are macrolide, who are recalcitrant. What do we mean about recalcitrant disease? Recalcitrant disease is a patient who has been on a form of guideline-based treatment, but ends up still being positive after 6 months of therapy. And so what are the options in that group of patients? The first is if they're on 3 times a week therapy, an option is to move to daily therapy. Another option in that scenario is to add clofazimine. There have been retrospective studies looking at doing both of these with a 30% improvement in culture conversion. However, these are both retrospective studies. You could also use bedaquiline. There's a very small study looking at you adding that retrospectively, and that also showed some improvement in conversion. But then he did discuss the FDA-approved drug Arikayce, which is approved for patients who are recalcitrant. Adding that to their regimen, we saw in a prospective trial that actually improves sputum culture conversion by 30%. And there is an ongoing study that's just being completed using Arikayce up front together with azithromycin and ethambutol, the Encore trial being compared to patients who are just on azithromycin and ethambutol alone. And we will hopefully by next year have answers on if that is an effective guideline-based regimen to start up front with Arikayce. We also had the option on I think it was the 3rd day of going to several different tracks. The conference highlighted a basic science track. It highlighted a pediatric track. It highlighted a primary ciliary dyskinesia track. There are a lot of support here in Australia. They have a phenomenally strong PCD foundation. And then there was a track for nursing and allied health professionals because it's extremely important to have education for all members of our team. And we do know how important it is to have nurses, nurse practitioners, respiratory therapists, nutritionists as part of the extended team that cares for patients with bronchiectasis. In the basic science track, I highlight a few of the speakers there that were quite phenomenal. Dr. Sanjay Chotarmal from Singapore was one of the key speakers in the research track. And he talked a lot about making clinical decisions individualized for patients using molecular methods of assessing patients' sputum, lower airway specimens, which we get from bronchoscopies, blood, and even stool is being looked at. So the microbiome data, the proteomic data, which is what we talk about at the molecular level, looking at patients from that perspective may give us answers in why one patient who has Pseudomonas is responding to treatment and another patient who has Pseudomonas may not be responding. There's more than what we're seeing at the eye level from just looking at a patient and looking at their culture results. Much of what is ongoing in each individual patient is happening at a super detailed level, like what we like to call the molecular level. And so we're able to get footprints on patients, looking at them particularly work that we're doing at NYU and NTM patients with Dr. Leo Segal's lab, is looking at their microbiome and how those patients differ from each other. So more information is going to be coming out that will be used to, hopefully we'll be able to get a simple test where we can get someone's microbiome data or their molecular typing of their sputum, and then use that together with some of the clinical findings that we have in those patients to decide who needs treatment and who doesn't need treatment. There was a rising star faculty member in this session, Rebecca Hull, who is looking at IL-7, one of the cytokines, to see how it helps predict exacerbations in patients who have bronchiectasis with Pseudomonas infection. So trying to find a biomarker that we can easily measure that may say this patient needs to be treated upfront rapidly because this patient is going to progress, whereas this patient with Pseudomonas, we don't need to treat. We may not even need to give antibiotics to, because they don't have this biomarker and won't need to be treated. Dr. John Iredell from Australia also gave a phenomenal lecture. Many of you are asking about phage therapy. We know that phage therapy is a little bit more advanced on the bacterial side, using many places within the world are starting to use bacteriophage therapy for resistant bacterial organisms like Pseudomonas. And so he described that a little bit, but the mycobacteriophage trials are still very small. In the United States, the main lab that is manufacturing phages for some of these small clinical trials is at the University of Pittsburgh. He discussed some of their work there that is being done by Dr. Graham Hatfull. And this is something that's being looked at still in the scientific area, but there is some hope that phage therapy will be something that we will be using for one of the treatment regimens in patients who have very recalcitrant disease. And there will be a study coming out shortly for inhaled therapy, phage therapy for Pseudomonas. So more to come on some of the newer therapies that will be coming out. Let me see what else I would like to highlight for you. Hang on, let me just grab this. There was also a phenomenal talk by Dr. Bernadette Prentice from Australia. She is a pediatrician. And so when we talk about early diagnosis, when I talk about it, I'm talking about, for us, the adult population. Our care network system and my clinic deals with patients who are 18 years and older. And so when we talk about early diagnosis, we're not reaching that pediatric group. The pediatricians are the first line providers who are seeing patients who may ultimately develop bronchiectasis. So what does that look like before you actually have bronchiectasis on your CAT scan? And so the pediatricians see children who have cough, persistent cough, with frequent exacerbations, as she noted, sometimes as many as 10 or more a year. And those children have recurrent episodes of very productive cough. Chronic suppurative lung disease is a term that is used. There is a guideline that's out there discussing that in children, and how that is often the precursor of, if left untreated or if treated improperly, will go on to develop bronchiectasis. And I wish I could pull up my slide. I did take a slide of her talk. She described patients with this chronic, children with this chronic suppurative lung disease who end up having even reversal of some of the bronchiectasis that is seen on their CAT scan, and who have reversal of Pseudomonas infection. So the thinking here is if you can diagnose this early enough, treat it appropriately with antibiotics that are focused on the organisms and not randomly given, you may be able to reduce the amount of bronchiectasis that then forms later on. And so I'm looking now to just get you the numbers of that study. And let's see. So the original article that was published with the lead author, Dustin Mills, radiographic outcomes in pediatric bronchiectasis and factors associated with reversibility, something we don't talk about in the adult population. They had 142 children, and 40% had resolution, and 39% had improvement. And there was no change or worsening in a group. So one of the predictors of those patients that did not resolve were Pseudomonas aeruginosus, was a predictor of not being able to resolve the bronchiectasis. But there is a paper, the Thoracic Society of Australia and New Zealand has a position statement on chronic suppurative lung disease in Australia and New Zealand. And the main aims of optimal management for particularly children and adults with this chronic suppurative lung disease, or we call PBB, persistent bacterial bronchitis, are to preserve lung function and halt disease progression, optimize their quality of life, and minimize the frequency and severity of exacerbation. So starting airway clearance very early, focusing on the sputum cultures and eradication of early organisms. All of these things can help prevent progression to clear-cut bronchiectasis. So I found her talk very promising, very optimistic. And this tells us that we really have to be educating not only our faculty experts in bronchiectasis and NTM, but we need to be educating our pediatricians, our general pulmonologists, our general pediatricians, our internists, who are seeing a lot of these patients early and at the first time where they may have an exacerbation. And so getting these diagnoses into the differential diagnosis of the general community of physicians that see patients with respiratory problems is extremely, extremely important. Today is the last day of the program, and on today's sessions are going to be looking at grade 2 phase 2 randomized placebo-controlled trial of a monoclonal antibody called Gremubab targeting Pseudomonas aeruginosa. So we are going to hear about that from Dr. Long from the UK today. We're going to also be hearing about alpha-1 antitrypsin deficiency and how that plays a role in bronchiectasis. And then we will be hearing about what the research priorities are going to be for this community over the next 5 years, and how we create a roadmap for the future so that we can work together with our patients and the priorities that all of you have together with our faculty experts, and make this an even better community so that we can deliver better care for the future. So on that note, I'm going to end, and I'm going to hand it back over to Mary and Amy.
Thank you.
Thank you, Dr. Addrizzo-Harris. Well, And I do want to say, I also found sorry, I don't remember her name, but the pediatrician who was talking about the chronic suppurative lung disease, very compelling and a very
Dr.
interesting
Prentice.
talk.
Yes.
Yeah.
Yeah.
We'll start with questions, and we only have right now 11 in the Q&A, but I'm going to start with one that I received through email. And before I ask this question, because this does have to do with the upcoming, hopefully approved brensocatib, brensocatib. I always mess up saying that.
Got it.
So I just want to say that we are working on a DPP1 inhibitor webinar that we're hoping to have towards the end of August or the beginning of September. So depending on how many questions we have in our time, we may not ask a lot of those questions, but I do want to ask this one. So it asks, do you think that brensocatib will replace the need for the big three antibiotics in patients with nodular NTM who are doing airway clearance, since it will reduce inflammation?
So that's a very important question. Just so that everyone knows, the trial did not include patients who were being treated for mycobacterial disease. In order to qualify to be in the trial, you had to have 2 or more exacerbations in the prior 12 months. You could not be immunocompromised in any significant way, and you could not be on active treatment for mycobacterial disease. So we don't really know how the drug will affect patients with mycobacterial disease. We can guess, and hope that you won't need antibiotics if you are on an anti-inflammatory medication. However, there were many speakers, including, I believe, Dr. Charlie Hayworth, who's done a lot of work in the inhaled antibiotic area, that many people are thinking there will need to be a multiple-pronged approach for treatment, where you may need antibiotics together with an anti-inflammatory, and then, of course, airway clearance. And maybe in the future, maybe you'll need more than one anti-inflammatory agent. There is a trial that wasn't discussed here that data will be coming out. The primary center was OHSU, Oregon Health Science University in Portland, with many centers across the United States, called the 2 versus 3 trial. And we were a part of that at NYU. That trial looked at using 2 drugs, azithro and ethambutol, compared to 3 drugs. And is azithro and ethambutol at least as good as the 3-drug regimen? And so hopefully by our conference in December, the North American conference, we have a pro-con debate on that topic, and that may be an option, that patients may only need 2 drugs instead of 3. So more to come. We will probably be needing a study to look at the patients that were not included in a lot of these anti-inflammatory trials. And so more to come, whether or not there will be a trial that is going to include patients that have NTM lung disease.
Thank you. Yeah, I think it's also important to distinguish that brensocatib is not an anti-infective. It's not an antimicrobial. So if you have an NTM infection, it's not something that will be used to treat the infection. So the answer of, whether to treat your infection is going to be a separate issue, depending on the progression of the infection. But I think the hope is that by addressing some of the inflammatory issues, it may help mitigate some of the progression of disease overall, and maybe help mitigate some of the risk. So I guess we'll have to see what happens. Those things are questions that get answered over time. So the next question up is it necessary to soak nebulizer cups in Dawn I occasionally feel that no matter how thoroughly I rinse, I still get residual dawn when nebulizing. Can boiling in distilled water be enough?
So I'm not the expert on
Yeah,
Dawn or
that's a,
using, yeah, I'm certainly not. And I don't think, there are any evidence-based guidelines in how much or how little we should be doing. Most of the nebulizers come with distinct instructions depending on the nebulizer. So that's what I would refer you to look at, and I would refer you to speak with your physician who's prescribing the nebulizer.
yeah, as I understand it from what I've heard from Dr. Falkenham in the past is the use of Dawn because it's such a good grease solvent. That's generally something that's
Okay.
used more like when you're talking about like a medication residue. So that might be part of the reason why it's recommended. But I think the whole boiling it is that's the sterilization factor. So I think those are questions probably
Yeah.
best geared toward Joe Falkenham and um, um, uh, to Jen Honda and other the other microbiology experts.
All right. The next question. Can you always get a MAC result with a sputum sample, or should you get a bronchoscopy to diagnose NTM?
So we should always be trying to get sputum first. If you don't spontaneously produce sputum, then making sure that you have an appropriate induction. An induction does not only include inhaling nebulized saline, but it includes sometimes chest percussion, huff coughing, using a positive expiratory pressure device afterwards to help enhance your ability to cough. So we will work with patients, fairly aggressively to do an induction. We usually have a respiratory therapist work with you while you're getting induced, because a bronchoscopy is still an invasive procedure. And so as you'll hear Dr. Daly from National Jewish say, they very rarely have to do bronchoscopy on patients. And I would say for us, that's pretty a standard. It's very rare that we will have to do bronchoscopies. But if you try, you cannot produce sputum, or you are producing sputum and it's not growing any MAC, it's not growing anything, but your CAT scan still looks suspicious or it's progressing, then at that point, we will move to bronchoscopy to get additional samples. So again, you shouldn't in most cases need a bronchoscopy, but if you're still sick and your cultures are not growing anything, then often a bronchoscopy is a good thing to add on to the regimen.
Okay. Somebody, I guess, was asking, I guess there was something you had mentioned about misdiagnoses that were mentioned, and I guess they were curious about some of the examples of that. So can you maybe go
Yeah,
into a little bit of detail on that?
sure. Sure. So many patients are misdiagnosed as having either asthma or COPD. Now, there are patients with bronchiectasis who have both, but that's the minority. And some of the treatments for asthma, particularly inhaled corticosteroids, will actually help patients, at least in the beginning, who have underlying bronchiectasis. So, but then the patients will come back and they will have repeated exacerbations, or as we heard from our pediatrician colleague, they will maybe they didn't initially have bronchiectasis on CT, but if they have recurrent exacerbations, that may then develop bronchiectasis on their CT. We know that many times patients do not have sputum collected. And so if you don't look at this, the sputum is a very good clue on who might be having underlying bronchiectasis. Pseudomonas is not something we see in the general community. Staph aureus is not something we see in the general community. So if a patient's sputum grows organisms that are not seen in the general community, there should be a light bulb going off in the doctor's mind that, there's something else going on structurally in this patient's lungs. And at that point, move on to a chest CAT scan, because we know in 99% of the cases, you do need a chest CT scan to make the diagnosis.
Okay. We've actually a question, and Doreen, maybe one of your UK colleagues has shed some light on this. Somebody's saying, "Hi, I live in the UK and have bronchiectasis. Do you know how I can get involved in clinical trials in the UK?"
So the patient group in the UK is called ELF. I don't, I believe it's the patient group in Europe. Don't quote me. And I would reach out to them because they have a lot of resources. And let me just
Well,
I'm looking it up now. Yeah, the
yeah,
European Lung Foundation is where I would direct you. Did you want to say something about that, Amy?
Yeah, so
actually, it's Mary.
oh,
Oh,
go ahead.
sorry. Um,
Mary.
so we're going to send out a follow-up email. Um, so I just want to say what we'll do is we'll send you some links on information in the UK for clinical trials. ELF and Embark are here at the conference, so we can touch base with them this morning. And like I said, we'll put some links for UK as well as for trials in the US to get you those resources. All right.
And yes, in
The
the
next
US, you can
question.
go to clinicaltrials.gov. And so Mary can send that link out, which will have all of our trials that we're doing.
Yeah. Okay. Hi, Dr. Addrizzo-Harris. I live in New York City and have bronchiectasis and MAC infection. I'm wondering how well known and recognized bronchiectasis and NTM are among pulmonologists in New York City. In your experience, is the awareness and expertise generally sufficient for receiving proper care locally, or is it often necessary to seek out a specialist like yourself who focuses specifically on these conditions?
So that's a great question. There's going to be a white paper, we call it, coming out from the American College of Chest Physicians, looking at the knowledge of internal medicine specialists and community pulmonologists. And unfortunately, when you see that article come out, there is a large deficiency, even in the general pulmonary community, of making a diagnosis of bronchiectasis up front. But it sounds like someone already made that diagnosis for you, and you know that you have bronchiectasis and NTM. And so I would, there are on, at least through the CHEST website and through the Bronch and NTM website, and Amy, I'm sure you probably have a primer for patients with NTM lung disease on the NTMIR website, of questions that you should be asking your provider.
Yes, we do.
And yeah, so and that will give you a good hint into whether if they should have answers for the questions. But you may, the first thing I would do, especially if you have a relationship with your physician, is ask them and say, how comfortable do you feel treating me for these diseases? There are many centers in New York City, not only ours, but many centers that specialize in bronchiectasis and NTM. And the only other reason I say that maybe you go to a center is because there are other things you can get at a center that you can't get from a general pulmonologist, and that is access to clinical trials. Plus, we are very interested in getting your samples for a lot of our biobanking and for a lot of the biomarker work that we're doing. Of course, those trials won't help you, but you may, by donating your sputum or blood, help patients in the future. So you can also decide to go one time to a center, get a full assessment, and then still go back to your general pulmonologist and have that person follow you more routinely. So I would start by having a discussion with your pulmonologist and then go from there.
All right. Mary, are you taking the next question, or do you want me to? I think I'm taking it. Hang on.
Yep, that's yours.
Okay, here we go. Next question. Is there any work being done to increase the early diagnosis of bronchiectasis and hypersensitivity pneumonitis? I've read where pulmonologists read CT scans with tree and bud and signet ring sign. I don't know that one. And still aren't
Mhm.
diagnosing bronchiectasis. Could we start using AI, artificial intelligence, to read CT scans, checking for early lung damage? I think they're already starting to look at potentially
They are.
using AI. So that's already in
Yes.
in progress. Yes.
Yeah, that's a great question. And it's so the signet ring sign is when we know that we don't want the airway diameter to be much larger than the associated pulmonary artery. The airway is black. And then the pulmonary artery is white. So when you have a signet ring sign, it looks like you've got a pearl sitting on top of a ring. And so that's not a good sign because that means you have significant bronchiectasis. And there was actually a session looking at talking about AI and how actually more precise AI is at making a diagnosis. But that's a whole another group where we need to educate. That is our chest radiology colleagues, and not just chest radiology, because a lot of CAT scans are read by general radiologists. So educating them not only to call it correctly, but we're very lucky in our center, our radiologists will say, here we see tree and bud, bronchiolitis, bronchiectasis, please consider non-tuberculous mycobacterial disease. So they will then go on to that next step to kind of expand the differential diagnosis. So again, educating the radiology community as well is extremely important. And a number of places are moving to AI. And in fact, for our registry, we're talking about using AI for a lot of the CAT scan data that we have. So you'll be hearing a lot more about AI in radiology.
All right. We are at the top of the hour. So we have a few more, we do have some more questions in the queue, and we will look at asking those when we do the
Mary,
follow-up webinar. Yes.
I will suggest if you want, you can send those to me. I can send back an email response to you, and you can send some of them out in the letter if you want to do that, since we
Okay,
can't get to
that would
them
be
this.
great. That would be great. Thank you.
And
So we'll do that. Um, and we want to thank everybody for attending today, and just remind you, we will be posting NTMIR and Running on Air. We'll be co-hosting a DPP1 inhibitor webinar. As Dr. Addrizzo-Harris mentioned, there are at least three studies, and we're anticipating on August 12th, the FDA approving one of the drugs. So for those people who asked those questions in here, we will be having that webinar. You'll have a lot more time to ask your questions. So thank you all again for attending today. And you'll get an email from Running on Air with just some information, some of the links we talked about sending out. And once the webinar is up online, we will be sending that out to you again too. So thank you all and have a great day.
thank you.